Okay, so my name is Rachel Kadar, and today we're going to talk about global function analysis, left ventricular function, and ultrasound assessment of cardiac output. I have no financial disclosures. So when I do all my lectures, particularly in the ICU curriculum, we talk about goal-directed echo, and we talk about the 5 assessments of shock. So we talk about left ventricular size and function, right ventricular size and function, pericardial effusion, intravascular volume status, and gross valvular abnormalities. And today we're going to talk about left ventricular size and function. So when we talk about that, we're going to do an ejection fraction analysis. And overall, we're going to try and do a qualitative assessment. So you're just going to look at the heart and you're going to ask yourself these 4 questions. Does the chamber size get smaller? Do the walls thicken? Does the mitral valve reach up and touch the septum? And does the mitral valve annulus move? And although we're focusing mostly on a qualitative assessment, I will give you some numbers or some calculations that you can kind of do to help train your eye with this. So does the chamber size get smaller? We'll talk a little bit about fractional distance shortening. Do the walls thicken? We'll just look at the walls and assess if they're thickening. Does the mitral valve touch the septum? We will talk about EPSS, or E-point septal separation. And does the mitral valve annulus move? We'll talk about MAPSE, or mitral annular plane systolic excursion. We'll briefly review the quantitative assessment of ejection fraction, which is Simpson's method, and we'll end with talking about Doppler assessment of cardiac output. So when we do point-of-care ultrasound and we're looking at LV function, point-of-care ultrasound recommends a qualitative approach to left ventricular function analysis, meaning that if you just look at the heart and you eyeball it, it's called the eyeball method, you essentially just visually estimate what you think that ejection fraction is. That visual estimated ejection fraction does compare to a quantitative calculated EF. So as long as you do this many, many times, kind of looking at the ejection fraction and guessing what you think it is and comparing it to the formal read, you will be able to train your eyeball for this. So when we do POCUS, these are the categories we use: hyperdynamic, which is more than 65, normal 52 to 65, mild to moderate. So in POCUS, we put mild and moderate together in the same group, 30 to 52, and then severe is going to be less than 30. And when I'm looking at this, I generally say, hey, is their ejection fraction normal? Is it hyperdynamic? Is it reduced? Or is it severely reduced? And those are kind of the 4 categories I'm trying to put the ejection fraction into. So again, these are the 4 characteristics that I'm going to, or 4 questions I'm going to ask myself when I'm estimating the LV function visually. So does the chamber size get smaller? Do the walls thicken? Does the mitral valve touch the septum? And does the mitral valve annulus move? So that first one, does the chamber get smaller? That's endocardial excursion. So if you look at this picture, that's going to be 1. So does that endocardium move in towards the center of my chamber? This can be done on a long axis. I will say that my peristernal short axis is my very favorite. I just put my finger or my cursor there in the center, and I just see, are all those walls moving in? 2 is going to be here, looking at that actual wall and saying, does that myocardium increase in thickness during systole? And so it should increase about 40%. So you can look here, here, here. You can look anywhere along the wall, but just saying, does that wall thicken when it contracts? EPSS is going to be E-point septal separation. So that's going to be, does this anterior leaflet reach up and touch the septum or appear to touch the septum? And that can help us estimate it. And then the 4th one is MAPSE, or mitral annular plane systolic excursion, which is shown right here. This is, does that lateral annulus of the mitral valve reach up and move towards that septum? And I talk about it in this lecture because I also think it's helpful to learn about TAPSE. And if I have a heart where all I can get is the apical 4-chamber view and I don't feel like I can see those endocardial borders or the myocardial thickening as well, just because it's more of a POCUS view, I can kind of look at the MAPSE and get an idea. So here's an ultrasound image that we can take a look at. And I like this image because it's a typical POCUS image, meaning it's not perfect, but it still gives us the information we need. So this is a very low peristernal long axis view where we see the left ventricle here, the left atrium here. Here's the anterior leaflet of the mitral valve. We don't even really see much of the LVOT or the right ventricle, but we can see here that we don't have great endocardial excursion. We don't have great myocardial thickening because the walls are already thickened. We don't have a good EPSS or a small EPSS as we would like. That anterior leaflet does not reach up and touch the septum. So this is severely reduced ejection fraction. So let's talk about the first question. Does the chamber size get smaller? In addition to visually looking at it, you can also calculate fractional distance shortening. And so to do this, we are going to measure the diameter of the left ventricle chamber in both systole and diastole. And we're essentially calculating that change in size. And this will estimate our left ventricular contractility. Of course, it's not accurate if you have regional wall motion abnormalities because that wall is not moving in and you might underestimate your ejection fraction. And of course, remember, this is just a diameter. So we're not looking at an area or a volume. So it's going to be less accurate. But as you're learning, it can still give you some information. In the parasternal long axis, you would do this at the level of the papillary muscles, but don't include them, in the short axis. And in the long axis, it would be just past the mitral valve leaflets and perpendicular to the anteroseptal and infralateral walls. So what does that look like? You're going to use M mode or motion mode across the ventricle. So this is a short axis view. Here's the circular left ventricle and the crest-centric right ventricle. And we have motion mode. So it's motion over time. So the x-axis here is kind of at different parts throughout that line you created. So this black or anechoic area in the center, that correlates with the anechoic or center of the left ventricle where the blood is. And again, here on this x-axis is going to be time. So here they're measuring that distance in systole versus diastole. You can see it goes a little further down here because we don't want to include the papillary muscle. And you can see the papillary muscle is right here. So we want to find really that edge of the endocardium. So here's just a little bit closer up view of that. Again, you have M mode or motion mode. And on the y-axis here is time. I might have spoke before, I apologize. On the x-axis, on the y-axis here is what the different parts of your heart as you're slicing through your ultrasound, and on the x-axis is time. So here's again that short axis view. We know we have a good view because we see both papillary muscles and they're kind of even, and our M mode is going right through the center. You can, of course, still do this in B mode, and that's how you do it on your ultrasound, but it's much easier to do in M mode or motion mode. So here's another picture, again, where you would get the edges in diastole and systole. And here's the equation for fractional distance shortening. And you would note that normal is greater than 30, severely impaired is less than 20, but you don't even need to memorize that because the sonocyte will give you the estimated ejection fraction based on this number. And that's kind of how we all think of function as an ejection fraction. So this is just a picture on our sonocyte. Again, you have a parasternal short axis view. We see both papillary muscles, so we know we're not at the level of the mitral valve, but hopefully just past it. This is going to be an M mode or motion over time. And you're going to have your distance in diastole versus systole. Again, this will tell you the fractional shortening is 21.7%, and it'll tell you that correlates to an ejection fraction of 45%. Here we have the same thing. Here you see this is at the level of the mitral valve. So these two lines you see here in the anechoic area, that's just a little bit of the edge of the mitral valve, but you can still calculate the distance in systole and diastole. The fractional shortening here is 27.9%, which correlates to an ejection fraction of 54%, so normal. If you do it at the level of the mitral valve, just know that that mitral valve annulus is fixed, so you might underestimate ejection fraction, but here our ejection fraction is normal. The next question is going to be, do the walls thicken? So this is myocardial thickening. The myocardium should increase in thickness by 40% in systole. In order to do this, as I look at my ultrasound video, I focus in on different areas of the wall and just ask myself if I feel that that wall is thickening. So let's look at a couple of videos where we can evaluate the ejection fraction. This is a parasternal short axis view. This one has normal ejection fraction. So if I put my cursor here in the center, I see nice endocardial excursion. Those walls are moving in. If I focus on the walls edges, I see nice thickening or myocardial thickening. So this is a normal ejection fraction. Versus this one, again, it's a POCUS view. So it's a parasternal short axis view. We might not see it quite as clearly, but we can still evaluate the function based on this view. And this one is severely reduced. So if I put my cursor here in the middle, These walls are not moving in nicely towards the center. They're not thickening. This ejection fraction is severely reduced. Let's go on to talk about EPSS. So this is our question, does the mitral valve touch the septum? So EPSS is actually the minimum distance between the anterior leaflet of the mitral valve and the septum in diastole. So when that mitral valve opens and that blood rushes into the left ventricle, how close does that anterior leaflet of the mitral valve get? And so we would calculate this distance. If we were to zoom in, it would be this distance. So as close as the mitral valve gets to the septum, that tiny distance. So as we look at this, a small EPSS actually correlates with a bigger ejection fraction. So again, to calculate the EPSS, you would do this in parasternal long axis view. You would put the marker or the M mode or motion mode over the distal tip of the mitral valve leaflet, and you would get this tracing. And so here, the star is where the anterior leaflet of the mitral valve is. So you can see that's the motion. This is your E wave and your A wave. So that E wave is that motion in early diastole when that mitral valve opens and blood rushes into the left ventricle. And then the A wave is going to be that atrial kick. And then right here, after the E wave, that's going to be in systole when that mitral valve is closed. So you're going to get this tracing, and your EPSS is going to be this distance, again, between the E wave and the septum, or that smallest distance. Of course, when you line this up, you want to make sure that you're lining it up such that you actually get that EPSS or that minimum distance, because if your angle is not correct, you might have difficulty actually lining up and getting that distance. Here's another example of what that looks like on M mode. So here is your E wave, and that's your septum. So this one is 2.3 centimeters, which is very large, which would correlate with a poor ejection fraction, as we'll talk about in the next video. But again, just to show that we want to get this M mode over that distal tip of that anterior leaflet of the mitral valve to try and get that minimum distance. So as we said before, an increased EPSS is going to correlate with a decreased ejection fraction. So if that blood isn't rushing into the left ventricle and it doesn't open wide, you're going to have it not reaching up and touching the septum. Whereas if it reaches up and touches the septum, that pretty much guarantees that we have a good ejection fraction. So again, we're going to do this qualitatively. So does that anterior leaflet of the mitral valve should appear to approach or touch the septum in early diastole? But if you want quantitative numbers, greater than 7 millimeters correlates with a poor ejection fraction. And here's alternatively some other literature and kind of what it correlates. So greater than 12 correlates with an ejection fraction of less than 30%. Another article says greater than 18 millimeters or 1.8 centimeters. But I like to make things easy, and 1 is an easy number to remember. So I say if it's greater than 1 or 10 millimeters, it's an ejection fraction of less than 30 to 40%. So of course, there are many limitations when we use EPSS. So this was actually created mostly for emergency department literature. They had emergency medicine physicians and said, hey, can you guess this ejection fraction? We're going to correlate your answer with cardiologists. And they said, actually, when using EPSS, they correlated pretty well. But of course, if you have mitral valve disorders, mitral stenosis, or calcification, we might not appropriately estimate our EPSS, or it might not correlate really with an ejection fraction. If you have severe aortic regurgitation, that blood is coming back into the left ventricle, and that might severely increase or inappropriately increase your EPSS. If you have LV dilation, and then of course it's a linear measurement again, so it might not perfectly correlate. So here's an example on the sonocyte. You've got M mode or motion mode through the anterior leaflet. You've got your E wave and your A wave, and you're measuring here this distance between the E wave and the septum. And this one is 0.57 centimeters, which would essentially correlate with a normal ejection fraction. So now let's do, sorry, I guess the answer came up before the video, but this one, you've got a parasternal long axis view. Left ventricle, left atrium, here's that anterior leaflet, and you can see that it's reaching up and hitting that septum. So we have a small EPSS, or if our question is, does the anterior leaflet reach up and touch the septum? The answer is yes. So this is a normal ejection fraction. And this one, oh, I apologize, it's not playing. But you can still kind of see, here's that anterior leaflet of the mitral valve, and it comes nowhere near to reaching up and hitting that septum. And if you were to get a number, you can note that it would most definitely be greater than 1 centimeter. So this correlates with a severely reduced ejection fraction. So our next question is going to be, does the mitral valve annulus move well, or MAPSI? So MAPSI stands for mitral annular plane systolic excursion, and TAPSI is going to be tricuspid annular plane systolic excursion. So TAPSI is going to be looking at the purple dot, whereas MAPSI is looking at the red dot. And you're going to put M mode essentially over those dots, depending on if you're looking at MAPSI or TAPSI. And you're going to be able to look at that annular displacement kind of towards that apex. And so your line should go through the apex and then through the lateral annulus. And that will tell you again about LV function or RV function. So again, MAPSI can help us evaluate left ventricular function. You're going to put M mode through that lateral annulus. And when you do, you'll see this hyperechoic or bright white area is that movement of the lateral annulus. And if you calculate this distance from the peak to the trough, that will give you kind of that excursion. And so the idea is that longitudinal and circumferential fibers will both contribute to this contraction and systole. And so we can evaluate the long fiber contraction. Now, the right ventricle has more long fibers, or more of its contraction is contributed from longitudinal fibers. And so that's why TAPSI is especially great for right ventricular function. But again, MAPSI can be just another thing in POCUS that you can use, especially if you can only get a view of an apical 4 chamber. You can use your your MAPSI to help you say, what's the function of the left ventricle? Here's the numbers, but I never just use them. I never, or rarely, I should say, rarely ever actually calculate the MAPSI, but again, just use the qualitative eyeballing assessment. Let's look at this. This is an apical 4 chamber view where we have LV, RV, LA, LV, RV, LA, and RA. And if I put my finger here and I look at MAPSI, we can say that this is a normal ejection fraction. So if I put my finger here, right, that lateral annulus of the mitral valve is moving up nicely towards the apex. Now, luckily, we can also here evaluate that endocardial excursion. If I put my cursor in the middle, the walls are moving in, and I can also see myocardial thickening. The walls are thickening with contraction. Versus here, this is an apical 4, but maybe almost a little bit of an apical 2 chamber. We're kind of starting to lose that right ventricle, but I do still see the left ventricle here and the left atrium. And I see that if I put my cursor here and look at MAPSI, this one is severely reduced. So, again, it's not a perfect apical 4 chamber view, but it still gives me the information I need, which is that my LV is severely reduced with my ejection fraction. So if I put my cursor here, you don't see that lateral annulus moving up towards the apex really at all. And so this again correlates with a severely reduced ejection fraction. And then I'll just mention it. So TAPSI would be tricuspid annular plane systolic excursion. Again, looking at the right ventricle, you would put M mode through the lateral annulus, and you would look at this excursion and measure this distance. And I put this in red because I think it's worth memorizing that a TAPSI is greater than 17 millimeters is going to be normal. Here's an example of TAPSI. And I use it to point out that this is not accurate because this should actually go through the apex and it's kind of cutting along here. So while this will still give you a number, this is not going to be an accurate TAPSI. And then just a reminder, the Sono said it will give you in centimeters. So if you've memorized it in millimeters, it's a quick conversion, but 1.97 centimeters would be 19 millimeters. So if this were accurate, this would be a normal TAPSI. But again, this is not an accurate angle. So to review our 4 characteristics to estimate left ventricular function visually: does the chamber size get smaller? Do the walls thicken? Does the mitral valve touch the septum? And does the mitral valve annulus move? Looking at endocardial excursion, putting my cursor here in the middle, do those walls move in? Myocardial thickening, it should increase by 40% in systole. EPSS, or does this anterior leaflet of the mitral valve reach up and appear to touch the septum? And then MAPSI and that 4-chamber view, does that lateral annulus of the mitral valve reach or move or become displaced towards the apex? Now we're going to go on to just review Simpson's biplane method. This is a 2D volume measurement. I don't recommend we do this in POCUS, but I find that most of you are very interested in knowing at least how to calculate it in case you go on to do a cardiac fellowship. So this is done in the apical 4 chamber When they actually do a formal one, they do the apical 4 chamber and the apical 2 chamber, and they average those. So this is essentially calculating a left ventricular volume from this algorithm that makes a summation of stacked discs to replicate essentially the left ventricle. And these go from the base to the apex. And this is created when you trace the endocardial borders on the ultrasound. And so it's calculating an end diastolic volume and an end systolic volume. And your calculation is going to be your end diastolic volume minus your end systolic volume divided by your end diastolic volume. And then when we do formal ejection fraction, you'll just notice that mild is going to be separated out from moderate. So moderate is 30 to 40, excuse me, and mild is 41 to 51. So how do we do this again? We want an apical 4 chamber view, and we're going to trace the border in diastole, and we're going to trace the border in systole. And this algorithm is going to make up a summation of these stacked discs, and it's going to use that algorithm to create a volume. So in order to do this, the most important thing is that we have a good image quality. So you would, if you're using the Sonosight, you go to a 4 chamber view, and you need to make sure that the LV is not foreshortened, meaning that this left ventricle has a nice pointy apex. Because if you're foreshortening it, then you're cutting off part of the apex, and your Simpson's calculation is not going to be accurate. You need to make sure that you see both the mitral valve and the tricuspid valve leaflets. You need to see both atria and the entirety of the atria. And the image quality has to be good enough that you are actually able to trace the border of the endocardium. So again, sometimes this kind of view can be difficult to obtain in POCUS, and we want to remember that if we do a calculation, if we don't have the ideal imaging, it could be inaccurate and lead us down the wrong pathway, which is why, again, that visually estimated ejection fraction is recommended. When you get this image, you're going to freeze, and you're going to scroll through to diastole. And if you want to do it on the Sonosight, you would hit calculations, ejection fraction, apical 4 chamber, and this upside down T here will appear. And then you're going to line this T such that the top of it, or the bottom because it's upside down, is at the mitral annulus, so here and here. And the other end of the T is going to be right at the apex. And you're going to hit trace. And this is going to form. So it's going to guesstimate where the borders of your endocardium are. And once you do this, you need to go around and you need to adjust these. So like here, I would move it in to actually match the border, and maybe move it out here and move it out a little bit here. So you're going to go around and kind of fix what the computer has automatically done to make sure it accurately reflects the size of the chamber. And then you're going to do the same thing in systole. And you want to make sure you use systole of the same cardiac cycle. So you're going to move that tracer forward in the cardiac cycle until you get systole. And again, you'll get this upside down T. You'll hit trace. And again, you'll move the borders out. You'll get this. And then when you hit done, it will tell you what the ejection fraction is. And that's how we would do Simpson's biplane. Now we're going to move on to talk about left ventricular stroke volume. So we can also use our ultrasound to calculate stroke volume. So if you remember, the stroke volume is the volume of blood exiting the LVOT in one cardiac cycle. So we can estimate, kind of visualize this LVOT and visualize that the LVOT is kind of like a cylinder. And if we want to know the volume of that cylinder, that will be our stroke volume. And so remember the volume, or if you remember, the volume of a cylinder is going to be the area of the circle. So that's going to be the cross-sectional area of the LVOT. And then the height of the cylinder. And the height of the cylinder is going to be our velocity time integral. And I kind of think of this as relating to the distance that one red blood cell will travel during systole. And that'll be your VTI. And so we're going to now talk about how to calculate both the cross-sectional area and the VTI. So again, just to review, and the ultrasound will do most of this, but just so you know where this is all coming. Again, cardiac output is heart rate times stroke volume. And our stroke volume is essentially going to be this cylinder that you see here in the upper right-hand corner. And it's going to be that volume of blood exiting the LVOT in one cardiac cycle. So if that's one cardiac cycle, remember you'd multiply that by your heart rate to get your full cardiac output. So we said that cylinder is going to be the cross-sectional area times the VTI. So the cross-sectional area, if you remember back in math a long time ago, pi r squared is going to be the area of that circle. And then your height of the cylinder is going to be the LVOT VTI, or velocity time integral. And again, I think of that LVOT VTI as that distance that one red blood cell will travel during systole. So then your entire equation would be cardiac output is pi r squared. We're going to just take the diameter divided by 2 and square it times the VTI times the heart rate. And this is how you can calculate the cardiac output with ultrasound. So to get the cross-sectional area of the LVOT, we want to get the diameter first of that LVOT. So we're going to do this in a parasternal long axis view. So again, indicator will be actually towards this right shoulder, parasternal long axis view, and we're going to measure this left ventricular outflow tract. We want to do this in peak systole, and a normal LVOT diameter is 1.9 to 2.3. And then that cross-sectional area will be pi r squared. So it'll just be that diameter divided by 2 would be the radius. So here we have that picture of a parasternal long axis view, left ventricle, left atrium, mitral valve, LVOT, aortic valve, ascending aorta, right ventricle. So we're looking here at that diameter. This is approximately where you're going to measure. This one is 2.02, and remember normal is 1.9 to 2.3. And this is probably a more accurate picture because we said we want to do this during systole. So here you can see that that aortic valve is open, and we're going to measure right here the distance of the LVOT, diameter, and systole. And here we have 1.96. So now we're going to move on to talk about the LVOT VTI. And this is what you're going to do is you're going to put a pulse wave Doppler in the LVOT. So if you don't remember pulse wave, go back and watch the lecture on physics. That is uploaded here, and you can talk about the difference between pulse wave and continuous wave. But a brief reminder is pulse wave is going to be the volume or the velocity of blood at a specific location. So you're going to take this sample gate and you're going to put it right here in the LVOT. And so we basically get an apical 4-chamber view, and you're going to tilt the tail of the probe down so your beam goes more anterior, because that's going to bring in the LVOT and the aortic valve. Because if you remember, the aortic valve is more anterior than the mitral valve. So now we have this LVOT and aortic valve. And you're going to put the pulse wave Doppler right here in the LVOT, and you're going to hit trace for your pulse wave Doppler. And you're going to be able to trace the systolic velocity curve that we'll see in the next couple slides. And then the computer will calculate the area under the curve. And you'll get a VTI, which will be in a distance. So 18 to 22 centimeters is a normal VTI. So here's an apical 4-chamber view, LV, RV, LA, RA. I'm sorry, it's actually a 5-chamber view. So here's your LVOT. And what you can do to start is you can put color Doppler over that to say, you know, as in the other picture, I didn't really see the LVOTs super clearly. So if I put color Doppler, now I can see that blood is all collecting right here. And at the LVOT, the location of it becomes more clear. And now that I have that, I can actually put that pulse wave Doppler in the LVOT. And that blood is going to be going out to the LVOT, so away from my probe. So it'll be a negative Doppler shift. So my line, I can see that during systole, that blood's going to go away. So I know I'm looking for a velocity curve that's going to go below my line. And here you see that these are nice scooped out waveforms, as I like to say, meaning that it's not filled in, but it's black here or anechoic in the center. And that tells me that I have a good positioning. And I also have here, you can see a tiny closing click right here, this little tiny thin line. And that also tells me that I'm in a pretty good location. So then once that happens, I would freeze my image and I can trace this velocity curve right here. And this one is 20.4. We said normal was 18 to 22. And so already I kind of know that this is probably going to be a normal cardiac output. Here's some other ideas or some other pictures so we can see kind of what this LVOT VTI tracing should look like. So here, this is an apical 4-chamber. Here you can see that this pulse wave Doppler is actually a little further, too far into my LVOT. And how we can see this is here, we have a really large opening click. So that's this line right here. And so that's telling me I'm too far in, that it's kind of the flow is a little too turbulent. In addition, I have a really large closing click as well. So again, this tells me that I'm not really in the correct location. And you can kind of see here, I'm a little too far into that LVOT. In addition, this waveform right here, it's more filled in. It's not really scooped out. So this is not really an ideal LVOT VTI tracing, but it's pretty close. Versus here, again, an apical 5-chamber view, LV, RV, LA, RA. and I have my form here. And this one has a small close and click. So there's that close and click right there, that really tiny one right here. And this suggests that we have that correct location. And then I have a scooped out waveform. This one isn't as scooped out, so I probably wouldn't choose it. But this one right here, you can see that black in the center, that correlates with a nice scooped out waveform that I could trace to get my LVOT VTI. So if we're putting it all together, we said cardiac output is heart rate times stroke volume. Stroke volume is cross-sectional area times the LVOT VTI. The cross-sectional area is pi r squared. So pi is 3.14. The radius is that diameter. If you remember, we got 1.96 divided by 2 squared times the LVOT VTI, which we said was 20.4 centimeters. We put that pulse wave Doppler, we traced that systolic velocity curve, and we got a distance. And I said, remember, that's kind of thinking as the distance that one red blood cell travels. So you put that all together, you get a stroke volume of 61.5 times the heart rate, the liters, 4.3 liters per second squared. And again, this is the overall calculation, but if you do this on the sonosite, it will calculate it for you. So we did all this, calculating the cardiac output, but can we just look at the LVOT VTI, and does this kind of correlate with cardiac output? So if you think about it, again, here's our equation. The stroke volume is the cross-sectional area times the LVOT VTI. But that LVOT size is fixed, right? So therefore, an increase in VTI is an indicative of an increase in cardiac output. And remember that normal range for the VTI is going to be 18 to 22. So we can essentially measure the VTI to assess stroke volume changes in response to a fluid bolus. And there's good literature to show that the estimate of that LVOT VTI can be an estimate of systolic cardiac function, and that in patients with heart failure, it can actually outperform the ejection fraction in predicting outcomes. And then there's also this idea of subclinical shock. So do you have a patient who has a low VTI despite normotension, but they're kind of heading down that way of subclinical shock, and next you're going to have their lactate come up, and next you're going to start to see signs of poor perfusion. So then another thing we could say is, this is looking at VTI as an accurate predictor of fluid responsiveness. So this is a study where they used VTI with a passive leg raise and showed that it was an accurate predictor of fluid responsiveness. So you did have an increase of VTI by 12%. This showed a favorable response to a fluid response. So this had a good sensitivity and specificity. So again, this is just showing an apical 5 chamber. You put that pulse wave Doppler, you get that scooped out waveform that you're going to trace and get a VTI. And again, that change in VTI with a passive leg raise correlated very well. So I often will do an LVOT VTI, and I'll do a fluid bolus, and then I'll check my LVOT VTI again to see, hey, did my fluid bolus that I just gave them actually improve my cardiac output? And if it's not, then maybe I need to stop with the fluid boluses and choose pressors or choose something else to try and actually increase that VTI if it's low. This is a study that looked at left ventricular outflow tract VTI was associated with poor outcomes in acute PE. So here, we said normal is 18 to 22. They said a low LVOT VTI, they defined it as less than 15. And they said that this low LVOT VTI was actually the strongest predictor of shock or need for reperfusion. And low LVOT VTI was actually associated with death or cardiac arrest, while RV dysfunction was not. So when they looked at all these different factors in these patients with high risk PEs, that the LVOT VTI correlated better with poor outcomes. So again, when I have patients in the ICU, I'm very usually quick to check their LVOT VTI and say, okay, I feel more reassured, it's normal, or yikes, it's not. How can I optimize this patient's hemodynamics? Because maybe I'm in subclinical shock, or maybe they're at risk for worsening. And in my PE patients, this is going to potentially even guide me being more aggressive with my interventions, knowing that they have a low LVOT VTI, they might be at risk for death or cardiac arrest if I don't intervene quickly. So again, today we talked about ejection fraction analysis. We talked about qualitative. So does the chamber size get smaller? That was fractional distance shortening. Do the walls thicken? Does the mitral valve touch the septum? So EPSS. Does the mitral valve annulus move, or MAPSI? And then qualitative, we talked briefly about Simpsons. And then we talked about Doppler assessment and cardiac output. So we talked about using LVOT VTI and using the cross-sectional area of the LVOT to calculate cardiac output. And we also talked about just using LVOT VTI independently to kind of assess for subclinical shock or volume assessment or potentially risk stratification in PE, using it kind of as an indicator for ejection fraction. Thank you very much for your time.